Hello guys, welcome to Fast Coder 21 Medical Coding YouTube channel. Today we are going to learn most important emergency department CPT procedures to know. So this session is useful for the people who are working in emergency department as well as the ambulatory surgery department. Even this session is useful for the people who are trying to enter into the medical coding field or the people who are trying to become CPC certified coder. So in order to understand everyone, we have created this session like question and answer type. We have question and we have answer too. We will learn answers using the CPT book as well as the some other resources. So in emergency department, incision and drainage is the most common procedure. So here our question is, why does the physician performs incision and drainage? So whatever is the procedure, whenever we code, we need to know the reason for that procedure. So usually physician performs incision and drainage for abscess. So what is the answer here? Incision and drainage is a procedure to drain pus from an abscess. A skin abscess is a pocket of pus in the skin. Most common CPT codes for incision and drainage abscess are 160 and 161. So 160 is incision and drainage of abscess, carbuncle, suppurative hidradenitis, cutaneous or subcutaneous abscess, cyst, furuncle or peronekia, simple or single, and 161 complicated or multiple. So in order to code 160 and 161, we need to know the difference between two codes. So 160 is for simple or single. 61 is for complicated or multiple. So what is meant by simple or single? Here, here with this abscess is very simple on the superficial layer, and single means physician will do only incision and drainage of single abscess. So what about complicated or multiple? Here complicated means physician may use multiple incisions, drain placements, extensive packing, and more complicated wound care. So which all are included in the complicated. So simple means only single incision, only single abscess. Complicated means physician may use drains, extensive packing, or more multiple incision. So which will comprises complicated incision and drainage. So next most important incision and drainage in the emergency department or in the ambulatory surgery centers is incision and drainage of pilonidal cyst, and we have two codes here 180 and 181. So here too 180 is simple, 181 is complicated. So we will check this code in the book. So what is in 180? It is a simple pilonidal cyst. So here physician will incise the cyst and he drains the cyst. So here 181 is complicated incision and drainage of pilonidal cyst. So what comprises complicated here? So the provider opens and drains the contents of a pilonidal cyst, a nest of hair and debris that forms at the base of the spine. The procedure requires extra time and technique to perform. So what happens here? Along with pus or cyst, the physician will remove nest of hair and debris from the spine area. Usually, these pilonidal cysts occur in the spine area, like end of the spine. And also, this complicated procedure requires extra time and separate techniques to incision and drainage of this complicated pilonidal cyst. So we have few more incision and drainage in this section. So we have 10140 incision and drainage of hematoma, seroma or fluid collection, and 10160 puncture aspiration of abscess, hematoma, bulla or cyst, and 10180 is incision and drainage complex postoperative wound infection. So 10140 is for incision drainage, hematoma, seroma or fluid collection. So what is hematoma here? Hematoma is a collection of blood outside the blood vessels. So in this series we have two codes, 10140 and 10160. So in 10140 physician will perform incision and drain the hematoma, seroma or fluid collection. So what happens in 10160? Here physician will puncture the abscess, hematoma, bulla or cyst. So basically incision is different, puncture is different. So incision is performed by the using knife. Like puncture is performed by the any type of sharp object. Basically these two codes, the purpose is same, but only technique of incision and drainage is different. Here physician will make incision, here physician will make puncture. So if imaging guidance is performed, we need to code 6942 77002 77012 77021. So in order to code this imaging, we need to check the operator report whether physician is using imaging guidance or not. So what about 10180, which is a incision and drainage complex post-operative wound infection. So post-operative wound means this occurs after the post-operative wound infection, like after any type of surgery. Here for secondary closure of surgical wound, we need to check 12020, 12021 and 13160. So mostly whenever we perform incision and drainage, we need to check whether it is simple or physician is making single incision or multiple incision, or physician is doing incision and drainage of single abscess or multiple abscess. Here, while as all of us know now, if it is single, we will code 160. If it is multiple abscess, we can code 161. Here also same way, if it is only incision and physician like drain the pilonidal cyst, we will code simple. And if the physician uses like packing or drains any drains in order to drain pilonidal cyst, we will use 181. So here 10140, this is also institution drainage of hematoma, seroma or fluid collection. Here in 10140, physician will make incision and drain the hematoma. In 10160, physician will create a puncture and he will aspirate the abscess or hematoma. So if imaging agent is used, we need to use this following 70,000 series codes. And 10180 is for post-operative wound infection, incision and drainage. So guys, in order to code this, we need to check the operator report properly. So we need to check the number of incision and we need to check the number of like abscess or cysts, and we need to check whether physician using drains or packing, or we need to check the technique of IND of the abscess or hematoma, and we need to check whether physician is using any imaging guidance or not. Next question, how do you code foreign body removal of skin? In order to code foreign body removal of skin, we have two codes like 10120 and 10121. We will check both codes in the CPT book. So if we check 10120, incision and removal of foreign body subcutaneous tissues, simple, and 10121, complicated. So we need to understand the difference between simple and complicated here. So what comprises simple here? The provider removes a foreign body such as stone or piece of wood, silver of glass or fish hook from the lower layer of skin. It is not complicated. So what happens to 10121, which is a complicated? So here provider removes stone or piece of wood or silver like that in the same way, but here the incision and removal may be complicated by the need for extensive dissection and imaging guidance or layered closure. So the difference between simple and complicated is here physician will make the incision and remove the foreign body, but in complicated foreign body removal, So physician will perform extensive dissection. He will use imaging guidance as well as physician will perform layered closure. So in order to code foreign body removal, we need to check the keywords. So if you find keywords like extensive dissection, imaging guidance, or layered closure, we need to use incision and removal of foreign body, subcutaneous tissues, complicated. So these three keywords we need to check: extensive dissection, imaging guidance, or layered closure. If you find any one of these keywords, we can code it as 10121, which is a complicated incision and removal of foreign body. Next question. What is meant by laceration? As you know, lacerations are more common ED procedures. So we need to have clear understanding of laceration terminology. So a laceration is defined as a tear in tissue caused by a shearing or crushing force. So because of force, if, we will have lacerations. So therefore a laceration is the result of blunt trauma mechanism. As all of us know, if you have any blunt trauma, we may have lacerations. Lacerations are typically caused by hard objects like a pipe, rock, or the ground. The crushing mechanism may have an effect on wound healing and scarring and increase the risk of infection from the devitalized tissue. So basically, laceration will uh, caused by blunt trauma. So we need to avoid traumas in order to avoid lacerations. So what happens if we have laceration based on CPT? We have three laceration repairs. Usually we will call it as wound repairs. So here our next question is, how many types of wound repairs in CPT for coding? So usually we have three wound repairs or laceration repairs, which we will call it as simple repair, intermediate repair, and complex repair. Here too, we need to understand the difference between these three repairs. So first, initially we will check simple repair. What do you call usually simple wound repair? So simple repair is used when the wound is superficial. So it is involving primarily epidermis or dermis or subcutaneous tissues without significant involvement of deeper structures. So as all of us know, our deeper structures comprises of muscles and fat and fascia. So here simple wound repair is for only for superficial, like wound is in the epidermis or dermis or subcutaneous tissues. So here we need to add lengths of repair for each group of anatomic site. So we will check CPT book for the clear explanation. So simple repair is superficial. So here it is involving epidermis or dermis. So here we will use one layer closure. So we need to check the keywords like the physician mentions one layer closure. We need to code simple repair, and mostly simple repair is involved in the most of the procedures. If the physician performs only simple repair, we can code this simple repair code. So next one is intermediate repair. Includes the repair of the wound that in the addition to the above, like intermediate repair include simple repair also. Require layered closure of one or more the deeper layers of subcutaneous tissue and superficial fascia in addition to the skin. So here, if you see here, for simple repair, one layer closure. For intermediate repair, layered closure. So these are the keywords we need to find in the operate report in order to code wound repair codes properly. So here even physician will perform closure of deeper layers of the subcutaneous tissue and superficial fascia in addition to the skin closure. Why means skin closure is already included in the simple repair. In intermediate repair, physician will perform repair of deeper layers of tissues, and physician will use layered closure in intermediate repair. And also in intermediate repair, physician will perform limited undermining. So physician will remove the skin under, sorry, muscle or wound fat under the skin, and he will pull the skin in order to release the tension. And also single layer of layer closure of heavily contaminated wounds that have required extensive cleaning or removal of particulate matter also constitutes intermediate repair. So you can find single layer and heavily contaminated wounds which requires extensive cleaning also comes under intermediate repair. So in order to code these, we need to check the documentation clear and properly. So next we will let complex repair. So complex repair include the repair of wound that in addition to the like intermediate repair require at least one of the following. So here what happens in complex repair? If the exposure of bone, cartilage, tendon or named neurovascular structure, debridement of wound edges, extensive undermining, so involvement of pre-margins of helical rim, vermilion border or nostril rim. So in order to code complex repair, we need to check the documentation whether wound has exposure of the bone, cartilage, tendon or any type of neurovascular structures. So one more keyword to use complex repair is placement of retention sutures. So we need to find all these keywords in the documentation. So necessary preparation includes creation of limited defect for repairs or the debridement of complicated lacerations or avulsion. So we will check the codes now. So 12,001 simple repair of superficial wounds of scalp, neck, axilla, external genitalia, trunk and or extremities. It is based on the lesion size. So usually these repairs we need to find in the centimeter. Even physician needs to tell in the centimeters. So if we have repair in the same anatomic sites, like for example, patient has repair on the scalp and neck, we can add both dimensions and we can code the single code. For example, a scalp has 1 centimeter, neck has 3 centimeters. We can code 12002 here. So we no need to code two codes here. We can code 12002 as scalps 1 centimeter, next 2 centimeter equals to 3 centimeters. You can code 12002 directly instead of multiple codes. So one is for these areas and 2.5 centimeters or less. 2 is for 2.6 to 7.5 centimeters. 4 is for 7.6 to 12.5. 5 is for 12.6 to 20 centimeters. 6 is for 20 centimeters to 30 centimeters. So and 7 is for over 30 centimeters. So here anatomical area is like different. So 12001 is different, 12011 is different. Here see simple repair of superficial wounds of face, ears, eyelids, nose, lips and their mucous membranes. Mostly 12001 includes face area or head area. So if we have head area laceration repair, we need to code from 12011 series. So we need to check the documentation to find where the wound is and where physician is going to perform repair. So this is also same as the previous one, double one, double three, double four, sorry, 14, 15, 16, 17, 18. So everything based on the centimeters. So we need to check the documentation to find how much centimeters physician is performing the repair. Next, we have repair intermediate. Here, sum of lengths of repair for each group of anatomic sites. So, if you have scalp and axilla, we can add both. Like that only. Here, 3-1, 3-2, 3-4, 3-5, 3-6, 3-7, 4-1. Here also again anatomical area is changed. So 4-1, 4-2, 4-4, 4-5, 4-6, 4-7. And here too anatomical area changed. This is intermediate repair only, but wounds of face, ears, eyelids, nose, lips and mucous membranes. So 5-1, 5-2, 5-3, 5-4, 5-5, 5-6, 5-7. So in order to code repairs properly, we need to check the area of the repair as well as the centimeters of the wound repair, like dimension. So for complex repairs, it is little bit different. See here, 13100 repair complex trunk 1.1 to 2.5 centimeters. So next one is 13101 2.6 to 7.5 centimeters. So what happens if the patient has 5 centimeters complex repair? We need to code 13101. Have you seen this guideline? For 1.1 centimeter or less, see simple or intermediate repair. So, if the physician performs repair of 1 centimeter or less, we need to check simple or intermediate repairs. So, 1310 is 02 for each additional 5 centimeters or less. So, we need to use 13102 along with 13101. So, 13102 is a add-on code. We can't code 13102 as a primary code. Here also based on anatomic area, the codes are divided. Here 13120, this is also complex. 13121, 13122. Here also we need to use the add-on code in order to code complex repairs. So here also anatomical area is different. Each additional 5 centimeters or less. Here also eyelids, nose, ears. So guys, basically we need to check the location properly in order to code wound repairs. And two things we need to understand: what is the exact location of the repair and what is the dimensions of that repair. So if we have these two criteria, we can code them properly. So and other thing, we need to understand the simple repair, intermediate repair and complex repair. So simple repair is single layer closure, it is superficial, and intermediate repair is it is layered closure and it will comprise of limited undermining. So third one is complex repair. If the repair is near to the bones or muscles or any complex, we need to code complex repairs. So here we have few questions. So if you know these questions, you can answer the interviews very properly. So how do you code if multiple wounds are repaired? So when multiple wounds are repaired, we need to add together the lengths of those in the same classification and from all anatomic sites that are grouped together into the same code descriptor. So as we learned previously, if the like the repair is in the same anatomic area, we can code both or we can add both dimensions and we can code it as a single code. And that also we can code in the if the simple repair, we can add the sizes in the both anatomic location. So we have an example in order to easily understand. For example, add together the lengths of intermediate repairs to the trunk and extremities. So here guideline is telling that we can add trunk and extremities. Why means here it is included trunk and or extremities. So trunk and extremities both are in the same anatomical area and repair is intermediate. So we can code or we can add trunk dimension and extremities dimension in order to code repair. And that also we can code if it is intermediate repair in trunk and extremities, we can code 12031 or intermediate repair. If the example, for example, patient has repair of trunk in using simple repair and extremities intermediate repair, we need to code both. Why means this simple and intermediate two both are different classification. So we need to code intermediate repair first as it is a complicated, and we need to code simple repair later. So next, for example, add together lengths of intermediate repairs to the trunk and extremities. As we have seen, both are in the same anatomical area. Do not add lengths of repairs from different grouping of anatomic sites, face and extremities. Why means face is in one anatomical area and extremities in different anatomical area. So we can't add face and extremities dimensions. Also, do not add together lengths of different classification. As we discussed just now, so we can't add intermediate and complex repair. For example, if the patient has wound repair in the two locations, in the intermediate, we can add if they are in the same anatomical area. So next question, how do you code if more than one classification of wound is repaired? So when more than one classification of wound is repaired, we need to list the more complicated as the primary procedure and the less complicated as the secondary procedure using the 59 modifier. Why means these are two locations. So we have an example here. So patient presents with 1.5 centimeter hand laceration and 2.5 centimeter forehead laceration, and provider performed simple repair on hand and intermediate repair on forehead. Report correct CPT codes. As per our guideline, when physician performs simple repair and intermediate repair, as these both are different classifications, we need to code intermediate repair first 12051, and second we need to code simple repair which is 12001 using 59 modifier. Next question, how do you code if physician mentions wound dimensions in inches or mm? So just now we got to know that we need to check the documentation for location of the repair and dimension which must be in the centimeters, as our CPT book mentions lesion like wound repair dimensions in the centimeter. So if the physician mentions inches, we need to convert them into centimeters. So for example, if physician mentions 1 inch, we need to consider it as 2.54 centimeters. And also if physician mentions 10 mm instead of 1 centimeter, we need to take it as 1 centimeter. So if the physician mentions 30 millimeters, we need to code it as 3 centimeters. Next question, how do you code if repair performs with derma bond? Answer, wound closed with only derma bond or other tissues, adhesive Medicare rule. So wound closures using adhesive strips or tape alone are not separately reportable. Usually it is included in the E&M service. So in the absence of an operative procedure, these types of wound closure included in the E&M services. If operative report is there, this derma bond is included in the operative procedure, but if there is no operative report, it is included in the E&M service. Under limited circumstances, wound closure using tissue adhesives may be reported separately. So in some situation, we can code wound adhesives separately. So if a practitioner uses a tissue adhesive alone for a wound closure, it may be reported separately with IPIX code G0168. So here the only procedure is using the wound adhesive, physician will repair, perform wound closure. Then we can code G0168. So if a practitioner uses tissue adhesive in addition to staples or sutures to close a wound, EPIX code G0168 is not separately reportable but is included in the tissue repair. So we need to check the documentation, what physician exactly is performing, whether he is using only tissue adhesives or and he is using staples or sutures to close a wound. So if he uses staples and sutures to close a wound as well as the tissue adhesives is included in the staples or sutures, we no need to code separately. So under the OPPS, HICPIC code G0168 is not recognized and paid. So outpatient prospective patient payment system, HICPIC code, we will not get money. So facilities may report wound closure using sutures, staples or tissue adhesives either singly or combination with each other with the appropriate code in the repair section of the CPT manuals. Basically it depends on the client criteria or client guidelines. So here use G0168 for wounds repaired with dermabond or other tissue adhesives, only skin. So next question. So basically if the physician performs only tissue adhesive closure, we can code it as separately. So if he performs adhesive closure along with sutures, we need to code only sutures, no need for tissue adhesive. Next question, what are the common nail procedures in CPT? So we have few codes here, like 11,730, avulsion of nail plate, partial or complete, single. Next one is evacuation of subungual hematoma, nail reconstruction or repair, wedge excision of skin of nail fold. Usually we'll call it as ingrown toenail, and 11750 is for excision of nail and nail matrix partial or complete. We will check these codes in the CPT book now. So if we check here, avulsion of nail plate, partial or complete, simple or single. So here what happened? In 11730, physician will remove the nail plate using the avulsion procedure, partial or complete, simple or single. So if the physician will remove additional, we need to code add-on code 11732. As per the guideline, we need to use 32 along with the 30. Which and next one is 11740, evacuation of subungual hematoma. So subungual means it is under the nail. Hematoma means accumulation of the blood. So in 11740, physician will evacuate the subungual hematoma, which is accumulation of blood. And the next one is 11750, excision of nail and nail matrix, partial or complete. Example, ingrown nail, deformed nail for permanent removal. So in order to code this one, physician usually give ingrown toenail. So that time we need to find this keyword. So in this one, keyword is subungual hematoma, which is a condition, and procedure is evacuation. So here ingrown toenail is a condition and excision of nail and nail matrix is a procedure. So in order to code in CPT, sometimes we need to check the condition also. So as ingrown toenail is a condition, excision of nail and nail plate is a matrix like procedure. So next one is 11755, biopsy of nail unit. So which is separate procedure. We can't code this code with the major procedure. So next one is repair of nail bed. Next one is reconstruction of nail bed with graft. Next one is wedge excision of skin of nail plate for ingrown toenail. So this is also condition. The patient has ingrown toenail and physician performs excision of ingrown toenail. We need to code 11765. Basically, we need to check the keywords here. So what exactly physician is performing, whether he is performing ingrown toenail or deformed nail, or whether he is evacuating hematoma, or whether he is like he is performing evaluation of a nail plate. In order to code nail procedures, we need to check the documentation properly. So for example, if you see here performing repair of nail bed. Here reconstruction of nail bed with graft. So reconstruction means, so using the graft, physician will perform nail bed repair. If you see here, if you have any nail procedure, just you need to check the anatomy of the nail so that it is easy to understand. See here is the nail matrix, eponychium, lunula, nail plate. So we have initial code is avulsion of nail plate. So physician will remove this nail plate. Here lateral nail fold, hyponychium, and already we have learned pinal nodal cyst. So basically in order to code nail procedures, we need to check the conditions like whether patient has hematoma or any type of ingrown toenail. So if we find these keywords, we can code it easily. So next one is how do you code burn care? Burn care we have usually 16,000, 16,020, 16,025, 16,030. We will check in the CPT book. So here 16,000 is initial treatment, first degree burn when no more than local treatment is required. So 16,000 for initial treatment, first degree burn. So first degree burn means it is less severe. So 20 is for dressings and debridement of partial thickness burns, initial or subsequent small. Oh, so we need to check the documentation for total body surface area. 25 is for medium. So 30 is for large. So we need to check the area of the burn also in order to code this burn codes. So if it is 5 to 10, we need to code 16,025. If it is greater than 10% of total body surface area, we need to code 16,030 code. So we have two codes as per our guidelines. So injection singular multiple trigger points or one or two muscles. So singular multiple trigger point, three or more muscles. So in order to understand trigger point injection, we need to understand how many muscles physician has injected. So as these codes are based on muscles, so if you physician performs one or two muscles, we need to code 20552. So if physician performs singular multiple trigger points, three or more muscles, we need to code 20553. Here we have one guideline. Do not report 552 and 553 in conjunction with 560 or 561 for the same muscles. And if imaging is performed, we need to code 76942, 7700,002 and 77,021. So you may confuse. We have trigger injection, trigger point is different, trigger finger is different. So we need to check the documentation, how many muscles physician is performing the injection in order to relieve trigger points. So if it is one or two muscles, we need to code 552. If more than, three or more muscles, we need to code 20553. Next question is, what is orthosynthesis and how do you code in CPT? So, which is one of the important topic in CPT. So, orthosynthesis, also called joint aspiration, is a procedure where a doctor uses a needle to take fluid out of a joint. So, actually, it is like aspiration of the joint fluid. So, orthosynthesis, aspiration, and our injection, we have four codes, like six codes. We will check in the book. So if we check arthrosynthesis, aspiration and or injection, small joint or bursa, fingers or toes without ultrasound guidance. So if the patient has arthrosynthesis of finger, we need to code 600 or toes 600. So why means fingers and toes are small joints, and first one is without ultrasound guidance, next one is with ultrasound guidance. So we need to check whether physician is using ultrasound guidance or not. If he uses, we need to code 604. If he is not uses 600. So, but this is only for small joints like fingers and toes. So instead of ultrasound, if physician performs fluoroscopy, CT or MRI, we need to code 77,000 series here. So next one is 605, which is intermediate joint. First one is small joints, which one is next one is intermediate joint. So if the physician mentions temporomandibular, orthosynthesis or acromioclavicular, wrist, elbow or ankle, olecranon bursa, so we need to take consider it as a intermediate joint, and we need to code 605 as well as the 606 based on whether physician has used ultrasound or not. And next one is 610, which is a major joint. See, for example, if the patient has shoulder joint orthosynthesis, we need to code 610 as based on CPT, shoulder joint is a major joint in order to code 610. So here also same like previous codes. Here also we need to check whether physician has used ultrasound or not. So basically in orthosynthesis codes, first one we need to check the documentation for what type of joint physician has performed orthosynthesis, whether it is a small joint, intermediate joint, or like major joint, larger joint. So if you check this one, closed treatment of radial head subluxation in child, nursemaid elbow with manipulation. So which is a closed treatment. So physician will not make any incision here. So just to close the treatment of radial subluxation means it is like displacement of radial head in child nursemaid elbow with manipulation. Here physician will perform manipulation using the hands, and he will perform the nursemaid elbow repair. So if you observe this one, if you find the nursemaid elbow in the documentation, as you know, nursemaid elbow is a condition. So closed treatment is a procedure. So in order to code this, we need to check sometimes we need to check the condition also in CPT book. Here in this example, nursemaid elbow is a condition. Closed treatment of radial head subluxation in child with manipulation is the procedure. So next question is, how do you code intranasal foreign body removal? We have one code here. We will check it in the CPT book, 30,300. So removal of foreign body, intranasal office type procedure requiring general anesthesia by lateral rhinotomy. So we have three types of nasal body removal, which is a office type procedure. So this is a simple procedure. It may be external of the nose. So here physician will visually remove the foreign body. In 310, physician may use general anesthesia, and third one is lateral rhinotomy. So in order to code this foreign body removal intranasal, we need to check the documentation properly. So what is the technique physician has used to remove the intranasal foreign body? So intranasal first one is 300 is very simple. Physician will remove it usually using the hands or the forceps. And 310, if the physician uses a general anesthesia in order to remove intranasal foreign body, we need to code 310. If physician performs lateral rhinotomy, we need to code 320. So rhinotomy means incision on the nose. So if physician performs lateral rhinotomy, we need to code 320. Next question, what is epistaxis and how do you code? So basically, as all of us know, epistaxis is nosebleed. So we have three techniques or three codes in CPT. We will check those in the CPT book. So if you check, we have 901, 903, 905, 906. So these are epistaxis. For epistaxis, physician will perform these procedures. So 901, control nasal hemorrhage anterior, simple, any method. So for if it is bilateral procedure, we need to add 50 modifier. So control nasal hemorrhage anterior, complex, extensor, cautery and or packing, any method. Here also 50 modifier. And control nasal hemorrhage posterior with posterior nasal packs and cautery, any method, initial and subsequent. So here also we need to check the keywords. So if the documentation contains anterior simple, we need to code 901. The documentation contains anterior complex, or whether if the physician uses extensive cautery or packing in order to perform epistaxis, we need to code 903. And this one is posterior with posterior nasal packs and cautery, any method, initial. So in order to code nasal this epistaxis procedure, we need to check the documentation properly. Here our keywords are anterior simple, anterior complex. Here we need to check the cautery or packing physician uses, and here which is posterior. So here you may find the keyword like posterior in the documentation in order to code 905. So we have next question. How do you code ET tube intubation? ET tube means endotracheal tube. So we need to know what is the purpose of this ET tube intubation. So what happens? Usually in order to maintain patient's airway open, physician will perform endotracheal tube. So we have only one code here, 31500. We will check it in the CPT book. So if you see here, intubation, endotracheal emergency procedure. So which is the emergency procedure? So next question is, how do you code chest tube insertion? We have one code 32551. We will check it in the CPT book. So our code is 32551. Tube thoracostomy includes connection to drainage system when performed open procedure. So basically in order to remove fluid accumulation, physician may perform chest tube insertion. Next question. How do you code placement of central venous catheter CVP line? So we have two codes for this procedure. We need to check 36555 and 36556. So we have two codes here, insertion of central venous access device. So usually we physician will perform this for fluid administration. So here central venous means here physician will perform insertion of non-tunnel centrally inserted central venous catheter younger than 5 years of age and age 5 years or older. So first 555 is younger than means less than 5 years, and 556 is for more than 5 years. Usually physician will perform for fluid administration or pharmacotherapy or medication administration. So here non-tunnel means it is not performed under the skin. Next question, how do you code intraosseous line insertion? We have one only single code 36680. So here our intraosseous infusion is 36680, placement of needle for intraosseous infusion. What happens here? Physician will insert the needle directly into the bone marrow in order to for intraosseous infusions or infusions drug directly into the bone marrow when intravenous access is difficult to obtain. So if it is not possible to obtain intravenous access, physician will inject medications or pharmacotherapy directly into the bone using the intraosseous line. So next question, how do you code vermilion border laceration repair? We have only one code 40650. So if you check here, repair helioplasty 40650, repair of lip full thickness vermilion only. So physician will perform repair of the vermilion border only. Next question, how do you code tongue laceration repair? We have set of codes. We will check those codes in the CPT book. So we have three codes for tongue laceration. So first one is 250, 251, 252. So repair of laceration 2.5 centimeters or less, floor of mouth, under anterior 2/3 of tongue, posterior 1/3 of tongue, and repair of laceration of tongue, floor of mouth over 2.6 centimeters or complex. Here we need to check the keywords. What are keywords? Floor of the mouth or anterior 2/3 of lung or posterior 2/3 of 1/3 of tongue. So we need to find or check these keywords. So exact location of the laceration, we need to code these laceration repair of tongue. So next question, how do you code drainage of abscess of dento-alveolar structures? So we have only one code 41800. We will check in the CPT book. So if you check 41800, drainage of abscess, cyst, hematoma from dento-alveolar structures. So usually mouth area like near to the teeth. Dento-alveolar structures means it is related to the teeth. Here physician will perform drainage of abscess, cyst, hematoma. So next code, how do you code IND abscess of peritonsillar area? So here we need to understand the exact location. What is peritonsillar area? So a peritonsillar abscess or peritonsillar area is an area of pus-filled tissue at the back of the mouth. So peritonsillar area is the back of the mouth. Here physician will perform incision drainage of abscess. We will check 4 to 700 in the CPT book, which is very simple. Physician will create or make one incision and he will drain the abscess in peritonsillar area, which is back side of the mouth. So next question, how do you code pharynx, pharynx body removal? So we have only one code 42809, removal of foreign body from pharynx. It is direct code, nothing is hidden. So how do you code IND of perianal abscess 46050, which is also physician will make incision and he will drain the abscess. So here we have code 46050. Perianal means this abscess is in the anal area. So next code, how do you code NG tube placement? Means nasogastric tube. So we have one code for NG tube. We will check in the CPT book. So if you check 43752, naso or orogastric tube placement. Naso means through the nose or oro means through the mouth. Tube placement requiring physician skill and fluoroscopic guidance. We need to code 43752. So next, in order to code following question and answer, we need to understand few terminology. So what is an involving catheter? An involving catheter is a catheter that stays inside the body for a longer period, and there are two types. In involving catheters, we have two types. So a urethral indwelling catheter is a catheter inserted through the urethra into the bladder, while a suprapubic indwelling catheter is inserted through the stomach directly into the bladder. So we have two types of indwelling catheters. One is through urethra and one is through suprapubic area. So next one, how do you code urinary catheter insertion? So we have two codes here. We will check it in the CPT book. 51701. So 51701 insertion of non-indwelling bladder catheter. So non-indwelling means it is not using for longer durations. It is just right catheterization for residual urine. So in order to remove residual urine, physician will use non-indwelling bladder catheter. So it is not for long term, it is for short term. So next one is 51702 insertion of temporary indwelling bladder catheter, simple or Foley. So here our exact keyword is Foley catheter. Physician usually tells Foley catheter in the documentation. Whenever you see Foley in the document, we need to code 51702. Next question is, how do you code Bartholin's gland abscess 56420, which is in the women's. If you check this one, incisional drainage of Bartholin's gland abscess. For incisional drainage of Skene's gland abscess or cyst, use 53060. So for this, we no need to worry. Physician will mention Bartholin's gland. So if you see this keyword, directly you can code 56420 for the incisional drainage of Bartholin's gland abscess. Next question, how do you code incisional drainage of vulvar perineal abscess? We have 56405 incisional drainage of vulvar perineal abscess. This code is for the female genital area. So how do you code drainage of scrotal wall abscess? This one is for male, 55100. So these are incisional drainage only. Just physician will create incision and drain a abscess. Based on location, we need to code. So 5640 is for vulvar perineal abscess. So usually it is for females, and 55100 for 55100 for male, as it is mentioned scrotal wall abscess. So next one is, how do you code lumbar puncture? So we have one code for lumbar puncture. We can check it in the CPT book. So here we have 62270 spinal puncture lumbar diagnostic. Diagnostic means in order to find the disease process, physician will perform diagnostic. So basically patient has symptoms, physician will perform diagnostic spinal puncture or lumbar puncture in order to confirm the any type of diagnosis using those symptoms. So if physician uses fluoroscopy or CT guidance, we need to code 62328. So next question is, how do you code nerve blocks? We have few codes. We will check it in the CPT book. 64400, 64450. So if you check here, 64400 injection anesthetic agent under steroid trigeminal nerve each branch. So trigeminal nerve includes ophthalmic, maxillary, and mandibular area. We need to, so here based on the nerve, we need to code nerve block. See here, these are trigeminal nerve, greater occipital nerve, vagus nerve, brachial plexus. Brachial plexus continues by catheter. So instead of injection, physician will use catheter in order to infuse the drug. Here axillary nerve, suprascapular nerve or intercostal nerve, single level, intercostal nerve, each additional level, ilioinguinal, pudendal nerve, paracervical nerve, sciatic nerve, femoral nerve, lumbar plexus or other peripheral nerve or branch. Basically, in order to code the nerve blocks, you need to check the documentation in order to find where physician is performing this procedure. What I mean, which nerve physician is performing the injection. Next question, how do you code I foreign body removal? We have few codes here, 65,000 series. We will check those codes in the CPT book. So if we check 65205, removal of foreign body, external eye, conjunctival, superficial. So external eye means it is visible to the physician with naked eye. 65210, conjunctival, embedded, subconjunctival or scleral, non-perforating. So inside the eye. 65220 is for corneal without slit lamp, triple T is for slit lamp. So if the physician uses slit lamp, we need to use 65222. If the physician does not use slit lamp for the corneal foreign body, we need to use 65220. Here 65235, removal of foreign body intraocular from anterior chamber of eye or lens. So basically we need to check the keywords here where physician is removing the foreign body and whether physician is using slit lamp or not. Next question, how do you code removal of impacted cerumen using irrigation or lavas unilateral? 69209 and 69210. So 69209 is for removal of impacted cerumen using irrigation lavas unilateral. So here our keyword is impacted. So we need to check the documentation in order to code this 69209. Physician needs to mention impacted cerumen. So we have guidelines here. Do not report 209 in conjunction with 210 when performed on the same year. So what 210, removal of impacted cerumen requiring instrumentation like unilateral. So 209 is for irrigation and lavas. So here physician will use saline type of liquid and physician cleans the ear. So but in 210 physician use instrumentation in order to remove cerumen. So we need to check the documentation in order to code this properly. What is the technique physician has used to remove the impacted cerumen from the ear? If physician uses irrigation and lavas, we need to code 69209. If physician uses 69 instrumentation in order to remove impacted cerumen, we need to code 69210. So if it is a bilateral procedure, we need to code 50, like 50 modifier. So next question, how do you code CPR? Usually CPR is cardiopulmonary resuscitation. We have only one code. We will code 92950. Usually physician directly mention we have performed CPR in the emergency department. Directly you can code 92950. So next one is how do you code cardioversion? So cardioversion code is 92960. In order to make irregular rhythm into sinus rhythm, physician will perform cardioversion. For that, we have 92960. Usually using cardioversion, physician will convert irregular rhythm into normal sinus rhythm. So next question, what do you know about moderate sedation? So basically moderate sedation is drug-induced depression of consciousness during which patients respond purposefully to verbal commands either alone or accompanied by light tactile stimulation. So basically it is not completely unconscious. So patient is depression of consciousness, but he is not completely unconscious. So here physician will instruct the patient to change the position using moderate conscious sedation. We have few codes here 99151 and 99157. Guys, we have tried as much as possible to include all the important emergency department procedures in this session. So if you need any procedure, any type of topic, please mention in the comment section so that we can make or create one session related to that procedure. So thanks for watching guys. If you like this video, please like, subscribe, share and comment. We hope you understand this session. Thanks for watching Fast Coder 21.